I'm grateful for the invitation to be part of this exciting forum for this conversation. For me, it's Old Home Week, because not only do I get to come and be part of an event put on by a really wonderful, innovative, forward-thinking area agency on aging, but I'm coming back to Massachusetts, which is really where I got my start in gerontology. While I didn't go to school in Boston, I did go to Holy Cross College, so an hour west on the Mass Pike out in Worcester. So for me, it's a little bit like coming home. So I'm really grateful to be here and to be part of this conversation. Our session today is called Driving Innovation Through Social and Healthcare Partnerships. And I wrote down all these notes, but I feel like the last panel set us up so well that I don't really need to give much of a preamble. You all get why these partnerships are so critical to meeting the holistic needs of older adults, of caregivers, of people with disabilities. And that's what our conversation is going to focus on. What the drivers are that are moving us toward this alignment, and how it is happening in the field every day, both in terms of healthcare as well as social care. So I'm going to introduce our panel, and then we're going to just dive right into the conversation. So to my left, I always have to think about this, because what you're seeing versus what I'm seeing. So for you, to my immediate left, we have Haney Abdallah, who is the President of Clinical Services with Commonwealth Care Alliance. To his, oh gosh, forget it. I'm going to get it wrong. Next, we have Jennifer Raymond, whom I get the privilege of working with on a very regular basis, which is wonderful, who is the Chief Strategy Officer at AgeSpan, another fantastic area agency on aging here in Massachusetts. After that, we have Dr. Guy Fish, who is the President and CEO of the Greater Lawrence Family Health Center. And next in our row of fabulous speakers, Amelia Bedri, who is a senior content engineer with the National Committee for Quality Assurance. And then finally, representing the home team of Somerville-Cambridge Elder Services is Cassie Cramer, who is a project manager with the Older Behavioral Health Network. So we have a wonderful panel to address this issue from a variety of different perspectives. So let's get started with our conversation. And I think, Guy, we're going to start with you. So over the past, I know, you get to go first. I'm the hot seat first here. But over the past decade, we know that the healthcare system has been moving from sort of volume-based care to value-based payment models. And that has catalyzed this movement. In part toward the integration and the alignment of health and social care. So how do you see value-based care models moving the system forward when it comes to addressing and providing holistic, integrated, patient-centered care?
The fact of the matter is that we're in America, and I think it was the Watergate era where they said, follow the money, right? If you want to understand what's happening in America or this country, follow the money. The money has, in this society, been guided towards medicalization. You've heard that term used earlier. Everything gets medicalized, and the doctor's at the top of the pyramid. And so we were being paid on a piece rate, which was called fee for service, right? And it's like the doctor is an auto mechanic, maybe your muffler shop. And the only way that at a community health center that you got paid more money was by seeing, having the next muffler and the next muffler come in faster and faster, right? So anybody, sort of relate to the fact that your physician visit now is about 12 minutes or maybe 10 or maybe 9 because you have to see more patients to get more money, right? So the value-based movement has a logical extension from focusing on volume to value. How is the health of the community writ large? And if you do that, you can redesign the system in terms of the payment to facilitate that so that under capitation, you are now asked to look at your panel of patients and see how are your hemoglobin A1Cs doing? How is your blood pressure management? Who's getting screened for depression? Who's being seen for depression after hospitalization or an ED visit? These are metrics that allow you to take a different approach. And instead of trying to see patients as fast as you can, see them as well as you can. But there's one other important difference, though, which is that we have the opportunity now to redesign our care delivery team so that the doctor is not the top of the pyramid, right? You need a team to care for the community. And so the doctor typically are very well trained to take care of the sickest patients. But there's a whole tier of people with 1 or 2 conditions. They're pretty stable. They need a little care management. Okay, the nurse team can do that. And then here's the really interesting thing that'll blow your mind, right? Which is that if you think of this as a pyramid, really sick patients, then patients with 1 or 2 diseases, down here, maybe 40% of the population, pretty healthy. Now, they may not be exercising or eating right, but they don't have anything going on today. How do you keep them from going up the pyramid, right? And that's where you begin to merge sort of public health and population health and these types of concepts, which under a capitation system, we're actually getting paid to take care of these people too. And we've never done that before. We need to change our care delivery model to include that type of approach, public health, population health approach.
Thank you. So next we want to turn to Amelia. And we know, the old adage, right? What gets measured gets done. So I know from our standpoint at USAging, we've been really thrilled to see organizations like NCQA, like the Joint Commission, like URAC, starting to turn their attention toward measure development as it relates to social needs screening and intervention, as we know you all have worked on for CAPS, and as part of your health equity accreditation, and other organizations are following suit. So what do you see as the role of measurement in driving this alignment of health and social care and advancing health equity?
Yeah, thank you so much for that question, and thank you for the opportunity to be here. I think just representing NCQA, we have a really unique opportunity as a nonprofit, independent organization that acts as a third-party evaluator, right? We're able to bring the lens through accreditation, through our quality measures, our HEDIS measures. And so, just kind of thinking about the approach that we bring, and Marisa, you mentioned our accreditation programs. So kind of starting with the integration of equity and social care, we have our health equity accreditation, which is eligible for organizations, such as different payers, various care delivery organizations. And, there are many states that have now mandated that, if you are a Medicaid payer, or if you are participating in and acting as a Medicaid accountable care organization, you must achieve the health equity accreditation. And we've really designed this program and many of our other programs to really tie and hold these organizations accountable for actually addressing social needs, screening for social needs, collecting demographic data. But then how are you as a payer, not just creating efforts, kind of to our panel session that was mentioned earlier, how are you actually investing in the community? And those organizations are accountable for demonstrating that to NCQA. And, this is big stakes, and them being able to demonstrate evidence of how they're investing in community-based organizations, building communities, and truly participating in community engagement, not just coming in, starting something and leaving, but, truly investing in long-term and sustainable partnerships with federally qualified health centers, with area agencies on aging, and with various community-based organizations that have roots in these communities. And so instead of duplicating efforts, how are you actually, investing in these communities? And so also just on the topic of aging, we have our 2 LTSS accreditation programs. We have our LTSS distinction, which is meant and designed for managed care organizations that are delivering long-term services and supports. And then we also have our case management for long-term services and supports, which really fits this audience of those AAAs, of community-based organizations. And so through those standards, we've really infused person-centered goal tracking. And how are you as an organization, working with patients and caregivers and ensuring that their goals are designed to meet their needs, and not your needs as the organization delivering the care. How are you, tracking care transitions and coordinating their care between various settings? How are you also infusing that equity lens and, how you're improving the actual outcomes? One thing about NCQA is we are big on collecting data, measuring data, but that doesn't take you anywhere if you're not actionable on the data. And so, that's kind of how we've infused those requirements of infusing equity and social care, and organizations demonstrating how they're leveraging that data to then improve the services that they're providing for their patients and ultimately, those caregivers. And so there are about 9 states that mandate that managed care organizations must achieve NCQA's long-term services and distinction, and then 3 states, Massachusetts being one of them, that leverages NCQA's CMLTSS accreditation for AAAs. So, and that's on the accreditation front. And then I mentioned with our, NCQA being a quality measurement organization, we've designed various measures, through social needs screenings, and having organizations, big payers, screening for social needs, but then appropriately referring those patients, to the appropriate interventions, and then reporting that back to NCQA so we can publicly, demonstrate that data and truly make it transparent about which payers in this space, are actually, talking the talk, they're walking the talk. And from there, we're also looking at stratification of those measures, because as mentioned earlier, there's a lot of intersectionalities between this population. And so how are you as an organization layering those intersectionalities to say, an individual belongs to various communities, and how does that impact, the care that they want to receive versus you as a provider or as a payer dictating the care that you think they should receive. And so those are kind of, the different ways through accreditation and through quality measurement, whether it's a state mandate, whether it's working with our federal partners to really try to get these organizations, to just go beyond collecting data, but use that data and demonstrate it to NCQA so that we on a broader scale, could really show, consumers in this space and make it really transparent.
Thank you so much. Now I want to turn to Haney. We know that Commonwealth Care Alliance has been a strong partner with grassroots social care organizations throughout Massachusetts, whether it's through the Senior Care Options Program, through Medicaid waivers and the Medicaid ACO work that Massachusetts has been at the forefront of. Tell us a little more about your work with social care partners to address population health.
Sure, thank you. Some of you might not know, I just joined CCA about 4 months ago, so today is my 4-month anniversary. And with that, I'm going to tell you a little bit about myself and also about CCA, and I think they're a little bit intertwined. So, show of hands, how many of you are familiar with CCA? Wow, we don't have to talk about CCA then. Incredible integrated healthcare system, and after the panel that came before talking about what Massachusetts has to offer and the innovation, I'm glad I made that decision to come here 4 months ago, because wow, did I choose the right state. And CCA has been an example of that. For those of you who know a little bit about the history of CCA, CCA started with our founder, Bob Masters, who I think a lot of you know, out of his kitchen with him and his wife. So small ideas can grow. And if you want to talk about innovation, started off with 73 members. We are currently at 50,000 members. Now, let's continue the innovation, right? 15,000 SCO members. Senior Care Options. Those are members who are nursing home certifiable, and we're taking care of them in the home. Sort of like a PACE without walls, right? And we are partnering with our partners, of course, our ASAPs, our FQHCs, our providers, and that's been core. We come from providers. I'm a primary care physician by trade, and to me, if someone showed me what our primary care offices are like, because that's what we developed. We developed primary care for the people who have unmet needs, and really to innovate for people with disabilities and people who need help. We go into people's homes to really figure out what their problems are because they can't come in. And if you've ever been in a primary care office and you've tried to take care of someone with a disability, first thing is, imagine them waiting in a waiting room. The chairs don't fit. Imagine them going through a hallway. You can't turn. Imagine the rooms, picture this, so small that the chairs don't fit. And even if they do, there's no room. Then let me go a step further. Try getting them off the chair, right? 15-minute visit for a follow-up, 45 if you're lucky. It would take you 45 minutes just to start the conversation. And that's what CCA has done. They've created these primary care offices. They've created home visiting physicians and practitioners to go into the home to serve this unmet community. But CCA can't do it on its own. It needs our providers, right? 25% of our members are being serviced or delegated to our providers in senior care options and One Care. We trust our providers. We want our providers to do the work. And because of where we come from, we want to pay the providers appropriately. We don't have to wait for the federal government to change policy. Being on the sort of upstream and being the payer, you're allowed to innovate. And boy, has this organization innovated, right? Could you imagine if somebody came to you 15 years ago and said to you, I want you to create a health plan that has 18 to 65-year-olds that have behavioral health, substance abuse, physical disabilities. I want you to take care of them, and I want you to do it under a capitated payment. Show of hands, how many of you would take that deal? 25,000 members, all with disability, behavioral health, substance abuse. And out of that comes the innovation, right? With that, we created Marie's Place, a crisis center that sort of transitions people instead of staying in the hospital where there are no beds, where they continue to revolve around. We created a home for them and a crisis unit for them, right? We created a member engagement center to continue that flow, to keep them connected to us, right? But most critical, we have to do it with our providers in the community. Without that, we're not able to grow. What we've also done, and I don't know if lots of you know, we've expanded. So we're trying to take what we learned here in Massachusetts and go across using our model of care and what we've learned here. So we moved into Rhode Island, started there. We moved into Michigan and California. So right now we cover over 100,000 lives. So I want to stay on the positive because a lot of what was said before was there's still a lot to go. And we talk about health equity and social determinants of health. But I want to tell you, 20 years ago, 25 years ago, 30 years ago, we called it something different. We know that what happens in the home isn't what we see in doctors' offices. And if you've had the honor, I call it the honor of entering someone's home, because you're invited in. It's not like when you go to a hospital, a nursing home, or a primary care office. You're walking into their space. That's a different type of care. That's a different type of methodology. And we need to continue to innovate and grow that. So I think we've come a long way, but we've got a lot further to go. So thank you.
Thank you. Well, now, Jen, I want to turn to you. We know AgeSpan has been a leader when it comes to network development and contracting with healthcare entities, which is the focus of what we do at the Aging and Disability Business Institute. And you've been really a leader among social care providers in that really valuable work. What has that meant for your organization, both in terms of your culture and your operations?
Thank you, Marisa. And first of all, thank you for all that you do at USAging to elevate the role of area agencies on aging and ASAPs and to create that right value proposition, awareness, education, training, so that we are now seen as the social care experts, the social care clinicians. So welcome to my turf now here in Massachusetts. And I think on this panel, you're seeing a reason why Massachusetts is leading the nation. We've got that partnership and seeds for deeper partnerships with social care experts, clinicians, with our community health centers, with our payors. The only thing that's missing here is the state role and their advocacy and the older adults who are screaming for improved care. So those are the legs of the stool that have made the success in Massachusetts. We still have a long way to go before it's the best state for aging for everyone in Massachusetts, but we're on the right path. When we think about the differences between the healthcare culture and operations and social care, it is overwhelming. We do a lot different. And what we want to start with is thinking about, okay, what are the things that we do similarly? What are the things that are common around a social care culture and a healthcare culture? First of all, we've got the same end game. We want our individuals and our communities to be healthy in their choice of living in the community that they choose for as long as possible. Don't want to lose sight of that, because that helps some of the other stuff be conversational if we've got the same mission at the end of the day. We have the same kinds of struggles with respect to serving large populations with not enough resources. Social care, as you heard Robin and others say, we get the short end of the stick when it comes to resources. I think the last time I checked, the Older Americans Act budget was about 1% of the CMS budget. So that tells you where we've prioritized social care up to this point. But we're all dealing with fewer resources than we need. So partnership is key. We, both from a social perspective and healthcare perspective, understand that the goal is not to address inequities, but to eliminate inequities in our communities. So that means the people that are being touched in the community health center and the people that are touched in social care, we understand that there are disparities and we have to focus on eliminating those. And then I think finally, one thing that goes understated about our commonalities and our operations and cultures is that we're struggling when it comes to workforce, when it comes to staff, recruitment, retention, satisfaction. I hear it all of the time with our healthcare providers, those satisfaction from people who have spent many years getting educated and now they only get 9 minutes with their provider and then hours of paperwork. So there are a lot more commonalities that I think we oftentimes think of, and starting with those things that are similar can help the rest of the conversation. The other thing I think, and we heard this a little bit earlier, is there can be the temptation on the social care side when we start contracting with the almighty powerful healthcare payors to adapt to their models, to adapt to their systems, to adapt to their culture. And we want to resist some pieces of that temptation. You heard the word over-medicalization, and I'm going to say it again because that is such a huge risk for us. When I hear Guy and others talk about the 9 minutes they have, and I think about our case managers driving to the person's home, going into the home, being able to spend time in the home, parking and saying, these sidewalks are not safe to walk on. I'm going to have to remember that when I talk to them about education, when I talk to them about exercise. Walking up the steps and feeling the rickety standard and say, here's a major fall hazard. I'm going to have to go back to the office and figure out how to get home mods in here. Sitting at the kitchen table and having the conversation and saying, I'm hearing that this person is lonely and isolated, I'm going to have to register them for the Conversations Massachusetts project that's coming up so that they could get connected. Being in the kitchen and seeing these cupboards are empty. Thank goodness I brought some food from our emergency food pantry, so I can give them food now, and then I'm going to go back to the office and we're going to start medically tailored meals tomorrow. That is I'm going to use the word luxury because we don't have it on the healthcare system as much. That's not to say the work is luxurious, because my case managers and our staff would hang me by the next tree if I said that their work was luxurious. But having that expertise, that time, that connection to community resources is a luxury, and the person that it benefits most at the end of the day is the consumer. And imagine I'm coming with food and you're going to have more food tomorrow. That is tremendous, and it happens all of the time. These are not anomalies. So we don't want to lose those parts of the social care structure, culture, and operations that lead to better outcomes. We've got to figure out how to pay for it so that we get paid for that time that we invest in learning not just what's the matter with the person, but what matters to them. There's not a billable code for that quite yet, but we don't want to lose those pieces of it. At the same time, we at OABHN, as well as Somerville-Cambridge and other ASAPs, have learned that there are improvements or adaptations that we want to make to take advantage of some of the really good things that are happening in healthcare and that we need to embrace on a social care side. First thing that comes to mind is the concept of quality. Now, if I will die on the hill that the ASAPs in Massachusetts are the highest quality community service providers for older adults across the country. No one will ever be able to convince me that. Our quality is really based on the number of people that we reach, the stories that they tell us, the impact that they tell us that they've made in their life. But when we talk with healthcare, it's almost like we're talking about quality with a lowercase q versus quality with a capital Q that focuses not only on quality assurance, but quality improvement. And so at OABHN and other ASAPs, we sort of said, like, okay, we're going to hold the mirror up to ourselves. We're going to hold ourselves accountable, and we're going to throw it out there and pull in somebody else to tell us how good our quality is. We're going to go for NCQA accreditation. Scary process, because it not only impacts, like, how do I apply to be accredited, but what are the changes to our infrastructure, to our staffing, to our internal investments that we have to make to hold ourselves accountable to that NCQA accreditation? Super helpful when we're talking with healthcare and we say we're NCQA accredited. They know we understand quality. Like, they know that we understand that. We just recently, I think on Monday, Chris Tardif, our COO, led us through our most recent NCQA site visit. And I know we knocked it out of the park, but you'll tell us differently or the same recently. But it has been a sort of a tool, not only to improve our conversations with healthcare, but to sort of improve our internal conversations. Like, what do we got to do to make sure that accreditation stays top notch? What investments do we have to make? Anytime you're talking about quality improvement, quality assurance, you got to talk about data. So how do we not only capture, but aggregate and analyze the data so that we're turning from a focus just on outputs to qualitative outcomes? What is the difference that medically tailored meals are making in the consumers that we serve? It is much more complicated than you would think, because one of the benefits of community-based organizations is that we are the masters at blending and braiding resources. So the federal dollars, the state dollars, philanthropy, business development, fundraising, all of those things, we for many years have been looking at how do we use those to budget to meet the needs of our consumers. Each one of those funding streams has a very different idea of what data they want us to collect in order to show success. So first of all, for every funding stream we have, I think we have a different technology or a different tool to gather that information in. Not only are the tools different, but the taxonomy is different. We might call something medically tailored meals for one payor and call it therapeutic meals for another payor and call it something else for another payor. So how the heck do you start thinking about aggregating data and comparing data to look at quality when we're not using the right languages yet? So at HBAN, we have also invested in a data strategy and in data consultants to sort of figure out, can we create a master taxonomy? We know we can't tell CCA, don't measure us this way, measure us our way. We know we've got to meet the needs of CCA. Will you listen? Yes. The way we collect data for CCA will be a different way than we collect data for the health center, and it's a totally different way than we collect data under the Older Americans Act. So we can't control how folks want it, but how do we create systems? So, it is a lot of that change. And the last thing that I will say is that it's not just a change in the culture and operations on the social care side, but we're starting to see that we can influence healthcare a little bit. A perfect example of this is we, in one of our contracts with an accountable care organization, we started out with them making referrals to us for, we want you to get medically tailored meals to this person. We want you to get a gift card to this person. Once we sat down with them, we realized if they're food insecure, they're probably income insecure. If they're income insecure, they might be housing insecure. If they're housing insecure, there might be behavioral health challenges. So don't send us a referral for 5 medically tailored meals a week. Send us a referral for further assessment. Send us a referral as a social care provider, a clinician, to go in to do that broader healthcare related social needs and come back with you and say, this is a proposed social needs plan. What do we have permission to do? So that culture shift and operation shift we're seeing is happening on both sides.
The question that we had for Cassie. We know behavioral health, we've heard it mentioned in the previous panel, Haney mentioned it now, and Jennifer, it's often viewed as a silent chronic condition. We would love to hear more about Somerville-Cambridge Elder Services Innovative Connect program and its impact. How are you leveraging the perspectives of people with lived experiences as recovery coaches and as peer specialists to improve services and look at behavioral health in a new way? And how does that fit or not fit with the current payment models that we have?
So for some context, some good news. Most people experience positive mental health. Research suggests that past experience of adversity leads us to gain wisdom and resilience as we age. This potential that we all have for lifelong mental health underscores the need for accessible mental health treatments. Older adults face many barriers to treatment. I won't get into those, and those are compounded by those who face additional cultural and linguistic barriers. And there's many risks associated with untreated behavioral health conditions. I experienced this firsthand when I began at Somerville-Cambridge Elder Services 15 years ago in protective services. So in this role, I found that a lack of in-home behavioral health support led people to be chronically at risk. They were developing preventable, devastating health conditions due to medical self-neglect related to a behavioral health condition, or they were at risk of homelessness due to behavioral health conditions like substance use or hoarding. I found that ageism and ableism were pervasive. Well-intended providers would often express their view to me that somebody didn't belong in the community and they needed to be placed somewhere because they had, both a behavioral health condition and were an older adult. I was fortunate that the management at Somerville-Cambridge Elder Services believed things could be different and we could be a part of the solution. They sponsored my participation in a grassroots advocacy organization, precursor to the Older Adult Behavioral Health Network, and Somerville-Cambridge Elder Services became one of the first ASAPs to pilot older adult peer support, or COPES, partnering with, I see the Somerville Council on Aging and the Cambridge Council on Aging to offer Buried in Treasures, a peer-led decluttering group. They also became one of the first ASAPs to pilot in-home behavioral health, initially through a suicide prevention grant and later through the Elder Mental Health Outreach Team funded by the geriatric line item in the Elder Affairs budget. So from its inception, Connect has been informed by peer and recovery-oriented practices, taking into account all the dimensions of our wellness: spiritual, physical, environmental, financial, social, and occupational. And the stories that have emerged from the Connect program through the pandemic are incredible. Connect has helped clients facing cancer without a support network, providing practical and emotional support through treatment. In one instance, helping someone resume life-saving treatment after she stopped due to depression. Connect sat with clients who experienced loss of loved ones during the pandemic without any friends or family. They help people find meaning after retirement. One person became active in the disability advocacy community and began leading peer support groups. Another learned how to use Facebook and connected with some college friends and went on a road trip. And this was a very socially isolated individual. Connect has helped people with hoarding conditions reduce clutter in the home to prevent eviction, reducing safety hazards in the home. We've helped clients move from apartments that they were essentially stranded in due to stairs, relocating to accessible units, and regaining access to the outdoors. And we've helped people with negative experiences with psychiatry, maybe somebody who was held against their will in an inpatient facility prior to commitment laws, or experienced bad side effects from early medications. Rethink mental health and begin seeing a new therapist or join a recovery learning community. But unfortunately, programs like Connect are not available throughout the state, and there's often a wait list for the programs. As state funding does not yet come close to meeting the needs. Programs like Commonwealth Care Alliance, a leader in behavioral health, reimburses in-home counseling and even holistic supports like acupuncture, which is incredible. And I wish that all my clients could enroll, but of course, you have to, be dual eligible, Medicare, Medicaid, and that's a barrier for people, as is sometimes people not being willing to change their providers. And there's few treatment programs that specialize in working with older adults, and insurance doesn't cover the cost of travel. Very few agencies are able to offer in-home counseling on a wide scale at all. But to end on some good news, due to the advocacy, largely led by peer and disability community and dedicated providers, programs like Connect are starting to spread throughout the state. We're thrilled that Elder Affairs hired a behavioral health program manager, Amanda Myers, who's here today. She's in this talk, but and this has been a lifelong dream of us older adult behavioral health advocates. We know that under her leadership, these programs will flourish and grow, and there's fellow innovators here I see in the audience. I see Age Strong that I know just dedicated significant grant funding to a number of new mental health initiatives, including growing the Certified Older Adult Peer Support Program. And I see you're sitting next to AARP and Sandra Harris, her work with Loneliness Isolation Task Force is really some pretty incredible work. So I will stop there. Yeah.
All right. Thank you so much to our panel for these really incredible answers and thoughtful conversation. While we had a wrap-up question, sort of set for the panel, I want to give you all a chance to talk. I would like to, take the moderator's prerogative to allow the audience to do some wrap-up, because I'm conscious of the fact that we didn't get Q&A in the last session, and I'm guessing, and I know I see a couple of hands already. Wow, lots of hands. All right, so I think we're going to start at the back, and we're going to ask you to sort of, yes, you, and please, and we have microphones that are coming around, so we'll ask you to wait for the mic and say who you are, and if you're with an organization, to give us the organization name too, please.
Yeah, my name is Jan Madamo, and I'm on the board of SCES. My question is, why is it patients who get their care at a hospital can't participate in a SCO?
What do you mean?
Whenever I get bombarded with these things
Yeah.
from all the different SCOs. And when I call, they want to know the names of my doctors. And I say who they are. And I said, they're at the Brigham. And they say, oh, well, we can't enroll you. And that has been repeated. So to me, I'll be perfectly honest with you, it smacks of our old attitude toward the poor that can't have the best. So I really would like to understand this, why it's so, and why haven't we fixed it by now? Thank you.
Sure, I'm not sure I know the exact answer to that, but Hospitals have to be participating in the health plans network. I will tell you that most health plans want all the hospitals in order to cover them. There's a negotiation between the health plan and the hospital. I can't answer for which specific hospital, but there's probably something that's stopping the hospital from contracting with us, or they're unwilling to. So hospitals have their own prerogative to choose which health plans that they want to partner with. But I have somebody here from CCA that would love to speak to you, and we'll talk about which hospital, and I can get more in depth on that. But yeah, it is about hospital network affiliations. It's not about the patients in the hospitals, and it's the network hospitals who want to participate with that. But we would love nothing more than to service more patients.
All right, we had a few more. Yes, down here, please. If you could wait for the mic, that would be great.
Hi, thank you. This is Carlos Rodarte. I'm the CEO of Veritios, a mental health care navigation company. Fantastic panel, wonderful answers. My question is around the value of social care seems so evident, and the people that are providing the care, from peer specialists to providers to nurse practitioners, are so immensely helpful, but so immensely underpaid. So as we start thinking about health equity, the integration of social care and medical care, what are the best tactics that you all can implement and that we can support to advocate for higher wages for all of the folks that are involved in social care programs? Thank you.
I could start if you want. Social care is not paid for. Health equity is not paid for. My colleague over here is trying to get NCQA to certify and get certain measures that we start to define what is health equity and what are social determinants of health. My view of social determinants might not be your view of social determinants, and it might be 18 or 20 other measures that I might be using. First thing we need to do is define it, right? Then comes the payment, and then comes the value. And I think we can all agree that government, whether it be the federal or the state side, is not looking to invest more dollars in the future. It will be based in quality. So it's either a take back or an addition to. So that's where the value is going to come in. And I'll just give you one example because this is the position that I hold. In order to do some of these visits in the home, it takes a half an hour to an hour to drive in Boston traffic. I thought New York traffic was bad. Wow, you guys definitely give us a run for the money in New York. Then you go in, look for parking, right? Climb up the stairs, go wherever. Then you start doing that visit in the home. The visit in the home could take up to an hour. That is not including the documentation that has to happen because they might not be able to connect. Then they have to drive to their next one. The productivity on that is about 2 to 3 visits per day. Add up the dollars. I don't think I need to tell you what the dollars are. They're expensive. No one's paying $600 to $800 a visit for one home visit.
I would add to that a little bit. I think we're fortunate here in Massachusetts that there are some strong advocacy organizations who understand the social care needs. I think of Mass Home Care, for example, and the work that they're doing on aggregating information related to salaries for social care clinicians at ASAPs, as well as providers in the home. I think of folks like the Mass Alliance of Community Health Workers who have done a lot to really understand what it is, these community health workers who are a godsend both in healthcare centers and in ASAPs, who go in and are of the same culture, are of the same language, and understand the needs of consumers on a health equity level better than any of us can. So doing the right understanding to say this is what a healthcare worker does. this is the outcomes that they lead to. They save you money, so how do we have that conversation? And then there are some things that are happening, even at a national level, that hold potential for being able to bring in additional revenue reimbursement streams for social care. I think the most recent example I can think of is CMS recently had a call for comment on the new physician fee schedule. And this is the first time that I saw in the physician fee schedule that they were looking at reimbursement for social care clinicians or allied workers or community health workers. The next question is going to be, okay, so who does that work? Is it a community health worker or an allied professional who is a member of the healthcare team and healthcare bills it? Or is it someone who sits in social services and social services is reimbursed for it? Or is it some kind of hybrid where a social care clinician sits in the health center and provides that work? So there are these nuggets of opportunity, and I think some of it will depend on how the crystal ball clears in the next few years.
I know, Guy, you wanted to take a crack at this question too.
Sure. So before I answer, I have a moment of true confession here. I know I started my life as an internal medicine physician, but I took a long walkabout on the dark side. I went to business school after practicing for a number of years and went to Wall Street and Boston Consulting Group, and then I found myself in venture capital. And so it's with some authority that I tell you that there's plenty of money out there.
Mm-hmm. We know that.
The question is the allocation of those dollars. Do they follow our values or do they follow some other principle? Now, the principle is that for 95% of us, for 99% of our lives, we really don't need medical care, right? We don't end up in hospitals, for years and years and years of our lives to any significant percentage. Most of the time, if you need a special, like super special procedure, thank God you're in Boston, right? I mean, it's amazing. But 99% of your life, you don't need that. All right. What you want is you want to talk to your doctor or talk to a nurse or talk to a clinical pharmacist or someone like that. And so we don't allocate the dollars. And one great example of that, looking at some of our wonderful healthcare institutions, I'm on the board of Beth Israel Deaconess. I know, okay, but I'm running a community health center. The difference between a medical center and a health center, right? Between a medical center and a community hospital, right? And so when a woman goes in to have a mammogram at Mass General or Brigham or Beth Israel, they're paid one amount. When they go to Lawrence General Hospital or Lowell General Hospital, they're paid a lesser amount, okay? I mean, the difference between $120 and $70 is a lot of bucks when you're paying salaries of people who are delivering the goods and services that we all want in a health center, not a medical center. So one of the things that you can do, Carlos, is this point is being brought up in a major way now with respect to the Health Equity Compact, which is legislation. And you heard Manny speaking to that earlier, right? The third wave, right? Access was the first wave, quality is the second wave, equity is the third wave. And you have to pay equitably for the same services. There's no reason why a community health center or a community hospital should be paid less for the same services just because they're not taking out TV ads.
I think we have time for one more question, so you get to be it.
I'm Janet Sackle-Serrati, and I'm the director at Friendship Works. And what I wanted just to ask is that we're still talking about, which is really important, government or government organizations or connected with the government mostly. There are a lot of community organizations, much smaller, that really have their hands in the community, whether it's the Portuguese group, whether it's a program like Friendship Works, who are so important, who really know the people and who don't get paid a lot, but who really can do a lot with less. But the money doesn't necessarily trickle down, and I don't want to use the word trickle down because I actually think it should be a partner. And I'm seeing some beginnings of changes, like where insurance companies are actually starting to be interested in organizations like us, or hospitals are saying, oh, maybe let's pilot something. But it's still, some of us who were here were last week at Harvard at a conference on building connected communities. And so when the healthcare community isn't talking to the other community organizations who are there, who really can make a difference in that 99% of the time, when it's not healthcare, but it is who's bringing you food, who's a friend, who's going to knock on your door so you're not isolated and that you're not depressed, that I know it's such a big picture, but how we connect with community organizations and give them the money that they need so they're not struggling, and I'm not spending so much time trying to fund, but actually I can spend more of my time making the connections that are needed. And if any of you have comments, I'd love to hear it. Thank you.
Yeah, I'd love to just step in there, and I really appreciate that question. And I think it ties nicely to the previous question of, as I was talking about earlier, NCQA through our accreditation programs, most recently our Health Equity Accreditation Plus program is all about that community relationship. How as a payer, how as, a federally qualified health center, how as a health provider, are you actually building these relationships? So the standards that we've developed go down to the fundamentals and the core components of these relationships. Because traditionally they've been transactional. It's what as a CBO can you provide to my members? How can you, reach these certain targets before we compensate you appropriately? And so our standards are now designed to say, how do you, as a payer that traditionally has more resources, has more leveraging power, and is, kind of this more dominant force in the healthcare ecosystem, really come to the playing field that these community-based organizations have, to say, how can we, create these goals together that are in your benefit? Because, ultimately, the health plan, the healthcare provider needs to support the CBO in order to then, appropriately impact the care that they can provide for the members and patients. So it's truly about redesigning the relationships that these organizations are creating, and we're doing that through our accreditation programs. We've seen California, will now mandate the Health Equity Accreditation Plus, and it's one of our newer accreditation programs, but, just kind of through the use of accreditation and also through NCQA's social needs screening measure, how, as a payer, are you appropriately referring patients to those community-based organizations that have roots in the community, and then also showing evidence of investing in those communities, just beyond, referring a patient to a service and then never following up, but actually, closing the loop, ensuring they were able to get connected with that resource. Did they experience any disparities or any barriers? Did they experience any discrimination or bias? Because those, a lot of that information never ends up getting reported back to the organization. And so, there's a gap of information there that, we're leveraging, and, we're commenting on CMS's proposed rules, and how do we streamline all of these definitions and terms to ensure that, these providers are appropriately, being compensated for. And so that's just, some examples of how NCQA is, playing in this space.
I just wanted to add one more piece to it. The lift for a social service organization to contract with a healthcare organization is astronomical. And when we think about, we at HBAN, we're a large social service organization with thank you, Tammy, a healthy budget. But it's investing in data, it's investing in infrastructure, it's investing in staff. So for there to be an expectation that all CBOs, all social service providers are going to have the resources to individually put that lift, we're not going to reach equity, because we're not going to include all of the CBOs that need to be at the table in order to reach the communities that we serve. So what we've seen a lot happening, and is happening in Massachusetts, is the development of social service networks, so that you might have a hub of a network. AgeBand has been a hub of a community-based network for a while. Mass Home Care has a very strong network and hub where there's a hub that can do the contracting with a healthcare provider and then subcontracts with a wide variety of community-based organizations. So a hub that's going to contract with CCA, and then that hub is going to subcontract with Friendship Works to provide medical escort services, to provide friendly visitor services. So not every CBO has to undergo that unachievable lift of meeting the standards that healthcare has, but we can do it through a hub. So I hope to see more of that work as well.
And with that, I think, well, do we have, okay, I'm getting this sign, we have one more. Okay, so
I just wanted to, thank you. I just wanted to follow up on your comments about the importance of community-based organizations. I, as CEO of the Massachusetts Alliance of Portuguese Speakers, we many times get people referred to us to help connect people with and to address the social determinants of health, addressing housing, food insecurity, mental health, legal services, you name it. And we are needed to provide that case management, but we're not at the table. It's obviously here, we're not here. Community-based organizations are not at the table. How can we make sure that we are at the table? And you just said it, it's for community-based organizations which are small like us, we don't have the capacity to be able to qualify, to apply for all the licenses and accreditations. So the importance for us to partner and is important. And I would say that the community, it would be critical for Commonwealth Care Alliance, for example. I know it does great work with seniors and has a large immigrant population that it serves. That many of the times those seniors come to us, and we really address so many issues, and we really are partners with our healthcare providers in keeping our seniors healthy. But we're not getting funded to do that at all. We have to struggle. We have to struggle to fundraise, to put on galas and more galas and more galas. And I have to tell you, I went to school to become to get my MBA. I never learned. I didn't take any classes on fundraising. But that's all I do now, is running and organizing social services. But it puts a huge strain on our organization. And just like it does for all the other community-based organizations. And so we need to be respected as equal partners at the table. We're caring for our population like never before. And in today's world, those of us who are working with immigrant populations are having to address undocumented elders. And undocumented elders is a huge issue that has not been addressed even today here, that needs to be addressed. Because we're seeing elders who are homeless, who are 85 years old and are still working because they have no way to pay for food or even for clothes, and much less housing. And we have some seniors today who are, instead of being at our senior center, can't be there because even though they're 85 years old, they have to be working. They're actually taking care of other seniors, so they can earn money to buy food and clothes. And we're helping them navigate this and keeping them, housed, which is a miracle. No one is acknowledging that. We're really helping fill a huge gap.
all right, I think we're getting people to start to filter back into the room. So I want to thank you for that last comment, because I think you really encapsulated what we've been getting at, not only through the first session, but this session. So please join me in thanking our panelists.